Hi everyone, this is Neil Wright, consultant audiologist and director of ClearWax. Thank you for joining me in my latest video using the iClearScope endoscope. I'll give you the patient's case history. So they visited a well-known high street hearing and optical company in the UK who are notoriously known to train people without any previous healthcare experience, let alone audiological experience. Just as long as you've got a proven track record in customer services, believe it or not. And I think they previously stipulated that an individual needs at least one GCSE in English, Maths or Science. But I've not seen that on their job advertising recently, so it still may be applicable. To have their ears clean, and they visited twice and they paid the privilege of £55, I believe. And after the second visit, the person who they saw initially said that there's still a little bit remaining, so come back after using some drops. They revisited, and the patient was told that the ear was completely clear. But as you can see, it's not only blocked full of, I would say this is more a bit of debris and dead skin, but they're suffering from otitis externa. Otitis externa is an umbrella term given to an infection or inflammation of the outer ear. And so normally with these cases, once we've treated the patient and removed all the debris and dead skin, we refer onwards to their patient's GP so they can have some medication prescribed. But the patient was failed of being notified that, and they visited the day afterwards because they still felt their ear was blocked. So the first thing we did, examine their ears, showed them on the screen, and the patient has been given a copy of the video, so hopefully they can go back and claim a refund. Now, I'm not quite sure what the individual performed this procedure. I'm surprised they even contemplated performing this procedure because it was very tricky and complex. As you can see, they've got a very narrow ear canal. Now that may be because there's a bit of edema, a bit of swelling because of their otitis externa, but it was difficult for me even to gain access. And secondly, they've got all this debris lining the canal walls. It would appear that they removed some debris from the entrance, because when I first entered the ear, you can see they had the appearance that some was removed, but that was probably about 5 or 10%. And for the patient to be told that the ear was completely clear and the eardrum was visible, and only the day afterwards they came here, obviously they were given the wrong advice. So what's really tricky about this procedure is going to come up a bit later. This patient's got some crystallized skin on their eardrum, and I didn't want to put any drops in this patient's ear to soften it because they have got otitis externa. Sometimes I do put some drops in despite them having otitis externa, just a moderate amount which I can then suction away almost immediately. But this patient has been using drops a lot already now. Their otitis externa may be as a result of overusing drops. So some types of drops can change the pH level of the ear. For example, sodium bicarbonate drops. Now, sodium bicarbonate drops are quite good for cases of keratosis obturans, and sometimes during a procedure, if a patient's got really mushy wax right up against the eardrum and olive oil isn't really benefiting me, I do put some sodium bicarbonate drops in then, but I immediately kind of clear the ear as well. If you excessively use sodium bicarbonate drops and also hydrogen peroxide drops, which is not really alkaline, it's more of an acidic pH, which mimics the pH of the ear itself. But both are water-based drops, and what water can do is macerate the skin, so it can break down the outer layer skin, which I'm not really keen on. And with sodium bicarbonate drops, going back to that, a lot of sodium bicarbonate drops in the UK also contain some alcohol, almost as a drying agent, but that can also over dehydrate the skin, causing it to dry and crack. And by altering the pH, you're more susceptible to more pathogenic bacteria colonizing the ear. Now, one of the purposes of earwax is to maintain what we call an acid mantle. We want the pH level of the ear canal to be around 5 to 5.5 on the pH scale. And at that pH scale, only really non-pathogenic bacteria can colonize the ear canal. Now, our ear canal is full of natural skin flora, and what skin flora is you have this ecosystem of bacteria and fungi that reside on the epidermis layer of skin, and they typically reside there harmlessly without causing any problems to the ear. The ear provides them with shelter and food. The ear canal doesn't really benefit itself by harboring the bacteria and fungi, but it's typically, I wouldn't call it a symbiotic relationship because that's when both parties benefit, but I forgot the actual name. There's a name given when one party benefits but the other party doesn't benefit, but it doesn't lose out either. But these bacteria that normally reside in the ear canal, they're typically what we call acidophilic bacteria. So they thrive in mildly acidic conditions. Now, some of the more harmful bacteria, particularly for the ear, are neutrophilic bacteria. So they thrive in more neutral pH levels. For example, Pseudomonas aeruginosa, which is also a gram-negative bacteria. So you get two types of bacteria. You get gram-positive and a gram-negative. Gram-positive bacteria have a thicker cellular membrane, whereas a gram-negative bacteria has a very thin cellular membrane. However, the gram-negative bacteria is encapsulated in a lipid layer, and that provides additional protection against antibiotics. Also, gram-negative bacteria are better able to mutate and become resistant to antibacterials, and once they are more resistant, they can pass on that genetic information to neighbouring gram-negative bacteria. So it just makes it much harder to treat with bacteria. So going back to Pseudomonas aeruginosa, you can find that also in simple tap water. And typically you find that bacteria in more complex companies and organisations like hospitals or healthcare settings where the water network, it's a lot more complex, there's a lot more piping, connections, and that's because where these pipes connect, for example, there may be some rust or a bit of a leak, and that's the perfect breeding space for Pseudomonas aeruginosa. Pseudomonas aeruginosa is actually one of the bacteria that's linked with malignant otitis externa, also known as necrotizing otitis externa, and that can potentially be life-threatening. So here's the tricky bit. You've got this dead skin here, so I'm literally positioning the suction tip on the eardrum and then gliding left to right. It wasn't peeling away any other way. Now I can see some of the eardrum already posteriorly, so they're going to be hearing better. Spoiler alert, I don't get all of this out. There is going to be some debris around the edges. It's a very difficult ear to work in because of how narrow it is. You can see the entrance is narrow. Once you're in, it does protrude outwards, it balloons a bit more, but it's still quite narrow. So particularly in the anterior recess on the right-hand side, I didn't manage to get all that out. I tried my level best, but the main thing is that this patient can hear a lot better. They've got their referral to their GP now. So they can get the appropriate medication. You can see the top half is still slightly crystallized. I did manage to get a little bit more out, but trying to remove any more would be a bit dangerous because there's only so much pressure you can apply. Now, the eardrum is a lot more robust than you would imagine, especially given that it's approximately 0.1 to 0.2 millimeters in thickness. And that's mainly due to the middle layer, the fibrous connective tissue layer. But, of course, it has its limits. So I managed to peel some from the top. It was difficult angling upwards towards the top of the ear canal because of the entrance of the ear that's so narrow, but I managed to just about get there. There's a bit of clarinetting there. You may have seen that skin flapping around a little bit, so I just came away for a moment. I'm just going to be careful we don't make contact with the bony part of the ear canal. You can see we're very, very close on the right hand side. So just trying to angle upwards, I think. I'm going to try and peel it from the top. Just see, I'm going just to the roof, but you can see I did make some contact with the canal wall, but it was very gentle, so they didn't really feel that, but I kind of moved away once I did. Normally, when you make firmish contact with the bone, this region of the ear canal, the patient does flinch a little bit because they can feel it. I've experienced a bit of discomfort there before in the past. I can resemble it to if you knock your shin against the side of a door or chair, for example. So it's quite an acute, sharp pain. So I've managed to just insert the endoscope a bit further in just to get a bit more depth perception. I'm just trying to peel this away. The thought process, if I peel this, it'll come away from the top. It's almost like you've got some sticky tape on some paper or an envelope, and you're trying to, like a stamp even, and you're trying to peel it away. But again, I just made contact with the eardrum there, and I'm trying to glide, but it's just a bit too stubborn. I think I managed to get a little bit here. So this part of the eardrum is the pars flaccida. It's actually thicker than the main body of the eardrum, but it's more elastic. And therefore it's more susceptible for getting sucked in. So that area of the eardrum is, you're just going to be extra cautious. So there's just some dead skin here. I'm just going to peel this away. So I'm just going to get some remnants around the edges. So when this patient does get their prescribed medication, it's going to penetrate the canal wall directly. You can see the skin's all macerated, broken down. But that's not really going to come away anymore, I don't think. So, the suction tip that we're using, I think it's the 18 gauge here. I'm using more the 17 gauge, which is slightly larger than the 18 gauge recently, but because this patient's ear was so narrow, I just went for the 18 gauge, which is a bit smaller. So let's see if I can get any more. I'm not sure I can. You can see the top part of the ear canal, it's got from both sides it channels in, and it's quite an acute bend there at the top. So it's like a V as opposed to a U shape at the top of the ear canal, which basically means I've got, I call it kind of a slit ear canal, this region anyway, where the height is significantly greater than the width. Now our ear canals, the height should be greater than the width to give it its oval shape, but in the pars internal region, so the latter third particularly, and also the outer third, the pars externa, the height is much more greater than the width. The midsection is not as bad. So again, I'm just trying to get to the top, peeling it down. So I have got access, but if I apply any more pressure, it's going to be, I think, a bit more uncomfortable for the patient. I managed to get this away, I think. It's even with the 18 gauge, there's not much space to work with. It can be quite frustrating because you've done the hard work getting access to this bit of skin, but it's just not peeling away. So they must have quite a prominent anterior recess, because you can only see the hammer bone. The rest of the eardrum anteriorly is hidden away by the front part of the ear canal, and that's why it's difficult to peel that. So even with the endoscope, we just can't view inside that region. So I'm just mopping up some dead skin at the entrance. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.